Traditional rotator cuff rehab tends to have a lot of banded external and internal rotation exercises, in addition to tons of scapular exercises. And although these can be good, in this video, we're going to share why that might not be the best starting point and how these exercises may be directly contributing to the problem. What's up, guys? If you're new here, my name is Dr. Brian Larish, and I'm the owner of a cash-based physical therapy clinic, as well as the creator of the PT Growth Academy. Inside the academy, we have the Clinical Coaching Specialist certification, where we teach movement professionals how to raise their standards and their results. Now, in this video, we're discussing how we can raise our standards when it comes to rotator cuff rehab. What you're going to learn by the end of this video is how to start to fix the source of the problem. A lot of the traditional ways tends to only focus on the symptom, which leads to short-term results. So with that being said, let's jump into understanding how we can improve our rotator cuff rehab. So the rotator cuff is made up of 4 primary muscles, 3 on the backside, 1 on the front side. It's widely known as muscles that externally rotate and internally rotate the shoulder, in addition to providing a lot of stability. Now, sticking with stability, stability is also synonymous with the term compression. And compression is usually what is the overlooked or underlying issue when it comes to someone dealing with some sort of issue here that would then make you do rotator cuff rehab. So if we turn our skeleton to the side, what I want you to imagine is that depending on someone's posture or pattern, they may have compression front to back. So when I say front, we're talking about the chest, the anterior side, and back, kind of this mid-shoulder blade. What would that look like? That would look like someone that is a little bit more extended and a little bit more in an anterior pelvic tilt. The response to that position is going to be compression. Now, the thing with compression is that it's always going to decrease space. So when we are compressed, we're going to decrease space at the shoulder, decrease space at the shoulder blade, decrease space at the rib cage. Everything is going to be jammed together or compressed. So often what we're dealing with is a space issue. The problem is the traditional physical therapy approach goes straight to external, internal rotation or shoulder blade exercises. But what is that doing? That's compressing everything. So we're adding compression on top of an already overly compressed area. How do you think the outcome's going to be? They might feel better short term because you got blood flow, but ultimately we start driving more compression and this person starts to get more and more dysfunctional. And it's a big reason as to why so many people only get short-term results but fail to get long-term results. So how we can improve our ability to get long-term results is first, creating space, respecting the rib cage, get someone breathing better, get this area to expand. Once it can expand and the person or patient has demonstrated that they can maintain that, then we can run wild with our ER, IR exercises because now they're in a position that they can be effective at doing those exercises. So, space issue, goal, expand. So let's jump into 3 exercises that we can gradually progress through to start to expand this anterior to posterior so that way we can get people out of shoulder pain. So the first place we can start is with a 90-90 serratus reach. The goal here is to bring the rib cage back to the shoulder blade. In doing so, we're going to increase space. From there, we want to start to drive breathing mechanics. When someone's in this compressed pattern, a lot of times they're just going through belly breathing motions. The problem with that is we don't get the expansion at the chest and we just get tighter and tighter. So pretty simple, we're going in 90-90. That means 90 at the elbow, 90 at the shoulder. From here, we're going to bend the knees a little bit. We're going to drive a slight posterior pelvic tilt to make sure we're not in that extended posture. And then we're going to make sure that the head's nice and relaxed. and we're going to press back. So we're engaging that serratus, pressing back. You should feel the rib cage come back, and we should feel a slight stretch at that mid-shoulder blade. From here, all we're going to do is maintain this position and work on breathing. Breathing should be inhale through the nose. You should feel a stretch, and as you exhale, we're trying to stretch enough to where we can feel the abs. This is just a sign that the rib cage came down enough. We need the rib cage to come down, and we need to anchor that in and hold that position, and then take another inhale. If we can effectively anchor the abs on the exhale, get them down, and then inhale and really feel that chest to back expansion, that's where we start opening tissues that have not been opened before. We're getting our patients or clients in a really good position. So that way, when and if they're ready for more of our ER and shoulder blade exercises, they're in that position that they can do so. Next, we're going to an all fours belly lift. This is essentially the same position that we had on the wall. Now we're just having it go against gravity. So we're just gonna make it that much more challenging. The biggest thing here is really giving proper cues. The cues here are critical to the success. Otherwise, we start to work muscles that we really don't need to be working. So what you're gonna do is go in an all fours position. Make sure that the hands are under the shoulders, knees are under the hips. And then we just go through 4 steps. Head down to make sure that they're not trying to pull air in with their neck. Chest up, that's that serratus reach. That's bringing the rib cage back. That's increasing the congruency between the shoulder blade and the rib cage. Then we have belly button up as our third cue, and then tuck the tailbone under the pelvis. That's that slight posterior pelvic tilt. This is helping them really get out of that extended posture that they want to be in. Once we're here, this is where the cues are really important. Don't just lift the hips up. Instead, cue them to push their belly button up so that their knees follow. What this does is it shifts the mindset from the hips to the belly button, aka the abs. So when we switch to this, it should be a very slow motion, and we just hover. From here, now we're taking 4 good breaths. In through the nose, out through the mouth. As they're going through that, they should feel abs and that upper back stretch. Finally, we're going to load it, but we're going to be intentional when it comes to the loading. Yes, we're going to work on the serratus reach. Yes, we're going to work on the stability of the shoulder, but we're also being cognizant of the rib cage. A lot of times when people are in that extended posture that we continue to talk about, the rib cage has a hard time compressing laterally. They're very compressed front to back and expanded, but what we want to do is start to compress laterally. So that's why a kettlebell arm bar is a great way to work on the full picture. You're getting the benefits from the rotator cuff side of things, but we're also checking off the box when it comes to the other components that are creating this dysfunction in the first place. So the kettlebell arm bar is as follows. We go on our back. I like to have people's heads supported because the neck tries to kick in a lot here. We have a kettlebell arm bar, a straight arm. We're going to drop the right leg. We're going to lift the left. And from here, we start to turn with the lower body. Once we get that initial roll from the hips, we then are going to punch up as we turn. So we're getting compression at the rib cage as we're getting this stability from the shoulder. Now, the neck shouldn't hurt because you should be punched. A lot of people run into pain because they lose that punch and then they hold with their head. And so the neck is now the stable point, not the arm. So if you can really keep that punch, the neck shouldn't hurt. Then when we come back, we are slowly controlling it coming back. Hold on to the punch. Don't let that punch go. And then we repeat. Turn from that lower body, punch. Use the punch as that stable point. Neck shouldn't hurt. And then we come back down. Again, a great way to start functionally loading for rotator cuff rehab.